Okay, we will resume the meeting. Let me bring one issue to everyone's attention. Apparently, I had a message from one of the liaisons that says that they do not have the raise the hand function on their screen. Is that a problem for other liaisons?
This is Sean O'Leary. I had to look. It's in the reactions place rather than the participant one where it used to be.
Thank you very much, Dr. O'Leary.
And Dr. Romero.
Yes, go ahead. I was going to ask you if you had any other comments. Go ahead.
One other point of business. It appears that we skipped over. You introduced Dr. Daly, but then in roll call we missed him. So we just need him to announce that he's here and indicate if he has any conflicts.
Dr. Daly, let me drop to my knees and apologize. So I'll call you to roll. Dr. Daly, are you here?
I am, and no need and no worries at all. So Matt Daly, Kaiser Permanente, Colorado, University of Colorado School of Medicine, no conflicts.
Thank you. At least I'm consistent because every meeting I have managed to miss somebody on the roll call. I cannot wait till we're back in session together and Dr. Cohen can backhand me when I mess up and I don't go public with it. All right. No
worries at all.
Let me go forward. Anything else, Dr. Cohen?
No, I think we can go ahead.
Okay. So moving on then, we'll hear the next presentation, which is by Dr. Campbell on the COVID-19 epidemiology among children. Dr. Campbell, please.
Okay, good morning. Can you hear me?
Yes, we can.
We can. Mm-hmm.
Okay, thank you. Well, good morning. It is my privilege to present on this topic for you today. Next slide, please. So I will give a very brief overview of COVID-19 in the United States, followed by the epidemiology of COVID-19 in children and teens, and lastly, discuss multisystem inflammatory syndrome in children, or MISC, which is a complication of SARS-CoV-2 infection. Next slide. Beginning first with the US COVID-19 epidemiology. Next slide. These first slides are from the CDC COVID data tracker. This one shows trends in number of COVID-19 cases in the United States. As of January 24th, more than 24.8 million COVID-19 cases had been reported to CDC, with the most recent 7-day average, as shown by the red line, of more than 168,000 cases per day. Next slide. As of January 24th, there had been over 416,000 deaths, with a 7-day moving average of 3,070 deaths per day. Next. And now moving to my specific topic, the epidemiology of COVID-19 in children and teens. Next slide. This shows the COVID-19 incidence per 100,000 population by age group. You will notice that the reported incidence of COVID-19 cases is lowest for children 0 to 4 and 5 to 17 years, as designated in the red box. I will emphasize that this is reported incidence. Multiple factors have contributed to underdetection of overall SARS-CoV-2 infections in children. These include limitations in testing availability, assay sensitivity, testing and reporting practices, care-seeking behaviors, and under-recognition of mild or asymptomatic infection. My colleagues at CDC have published a statistical model based on methods previously used to estimate the disease burden of influenza to account for under-ascertainment and adjust nationally reported COVID-19 case counts to better reflect the true number of SARS-CoV-2 infections, which I will show you in the next slide. Next. So the data on this slide are on the CDC estimated disease burden of COVID-19 webpage. Adjusting for underdetection, estimated SARS-CoV-2 infection rates per 100,000 population are lowest in children 0 to 4 years, but for children 5 to 17 years are basically the same as for adults. Next slide. This slide shows data from a study that evaluated SARS-CoV-2 seroprevalence in children less than 18 years. I apologize for the dog. The study used residual serum samples from May to September performed by the University of Mississippi Medical Center, which provides clinical laboratory services for university hospitals statewide. Next slide. 1,603 people were tested, and the overall seroprevalence was 10.9%. Next. Seroprevalence was higher among non-white children. Specifically, seropositivity among Black, non-Hispanic, and Hispanic children was 2.4 and 4.3 times higher, respectively, than that among white, non-Hispanic children. Next. And seropositivity in children increased over time from 3.5% among samples collected in May of 2020 to 18.2% by September. These estimates help us to track infections among children. In fact, compared with seroprevalence data from older age groups in Mississippi, data from this sample suggested that cumulative infection rates by mid-September among children were similar to those among adults 18 to 49 years, which was the age group with the highest seroprevalence. Next slide. To gather data on susceptibility and understand the role of children in transmission, CDC is supporting a case-ascertained household transmission study with Vanderbilt University in Tennessee and Marshfield Clinic in Wisconsin. An initial analysis of the data was published in an MMWR, and the data I'm showing today include enrollments between the study start in April and November. In brief, index patients are enrolled from outpatient clinics if they have lab-confirmed SARS-CoV-2, symptoms for less than 7 days, and live with at least one other person who has not had acute illness in the past week. All enrolled index patients and their household members were followed for 14 days with daily symptom reporting and self-collected nasal swabs to look for secondary transmission. Next slide. Thus far, the study sites have enrolled 147 index cases who were enrolled a median of 3.5 days after illness onset. 306 of their household contacts have been enrolled. As you can see in the bar graphs, the index patients are more middle-aged than the household contacts. In total, the sites have enrolled 22 index cases who are children and 118 household contacts who are children. For the analysis I'm showing, households that had co-primary cases and contacts who were likely tertiary cases were excluded. After these exclusions, 78 household contacts, or 49%, were positive for SARS-CoV-2 in follow-up. Next slide. So this is among those 78 people with secondary infection. You can see in this figure that younger children, less than 12 years, in the leftmost dark gray bars, in general, were less likely to be symptomatic and had many fewer symptoms than adults in the rightmost purple bars. Next. This figure shows the secondary infection rates plotted by the age of the index case to help understand age-related differences in transmission from the index case. In general, we see that symptomatic children in the top 2 age categories can transmit SARS-CoV-2. The sample size is most robust in the adults 18 to 49 years, and there are overlapping confidence intervals around the estimated secondary infection rates. But in looking at the point estimates, symptomatic children seem to transmit SARS-CoV-2 less frequently than adults 18 to 49 years. Next. This figure shows the secondary infection rates by the age of the household contact in order to look at how susceptible different age groups are to SARS-CoV-2 infection. You see that children who were exposed in the household had a similar risk of secondary infection as adults. Next slide. A similar study was conducted as a field investigation in Utah and Wisconsin earlier in the spring of 2020. These data are published in Pediatrics, and they found that secondary infection rates were similar among pediatric and adult household contacts. Or in other words, children were as susceptible to SARS-CoV-2 infection as adults. Next slide. Now I'm moving from our outpatient look at susceptibility and transmission to the hospital. This is a figure from the COVIDNet hospital surveillance system showing laboratory-confirmed COVID-19 hospitalization rates per 100,000. You can see that children less than 18 years have the lowest cumulative rate of COVID-19 associated hospitalizations. And those rates are 35.4 and 21.2 per 100,000 for 0 to 4 and 5 to 17-year-olds respectively. Here for simplicity, compared with all others age 18 and older, with a rate of 460 per 100,000. Next. Although children with COVID-19 may have mild or no symptoms, children can get severely ill from COVID-19. We still have a lot to learn, but children with underlying conditions, certain underlying conditions, may be more likely to have severe illness. These include asthma or chronic lung disease, diabetes, genetic, neurologic, or other metabolic conditions, sickle cell disease, heart disease since birth, immunosuppression, medical complexity, and obesity. Next slide. Looking at further data from COVIDNet, 52% of children less than 18 years hospitalized with COVID-19 had an underlying medical condition. And if you look at the leading condition here, it's obesity, which is between 35 to 40% of the children. This is followed by asthma and other chronic medical conditions. I will just note as an aside that for influenza, the obesity proportion is more like 9 to 10% of hospitalized children with flu. And the leading underlying condition for influenza is generally asthma, among 15 to 20% of the lab-confirmed flu hospitalization. Next slide. Here are additional data from COVIDNet showing that children are about similarly likely to be admitted to the ICU at around 30% for hospitalized children and adults. But children less than 18 years hospitalized with COVID-19 are less likely than adults to experience mechanical ventilation or in-hospital death. Next slide. And I'll end my overall COVID slides with this figure showing COVID-19 mortality rates. Note in the red box at the bottom that for children, there is a 0.4 to 0.3 per 100,000 mortality rate for children, which increases significantly as you move up to the older adults. Next. For the last section of my talk, I will give an overview of multisystem inflammatory syndrome in children, or MISC. Next slide. So MISC is a severe inflammatory syndrome that was first recognized last April in the United Kingdom, occurring in children with current or recent infection with SARS-CoV-2. MISC is thought to result from delayed dysregulated host immune response, generally delayed 3 to 4 weeks, but this can be a wider range of 2 to 6 weeks from the preceding COVID-19 illness. And often, MISC occurs with no known preceding illness. By May of 2020, cases were reported in New York City and New York State. And on May 14th, CDC issued a health advisory requesting healthcare providers to report patients less than 21 years meeting MISC criteria to local, state, or territorial health departments. Next slide. This is the case definition. It's an individual aged 21 years presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multisystem, which is 2 or more organ systems involved, and no alternative plausible diagnoses, and positive for current or recent SARS-CoV-2 infection by RT-PCR, serology, or antigen test, or exposure to a suspected or confirmed COVID-19 case within the 4 weeks prior to the onset of symptoms. Next slide. This MMWR, published August 14th, 2020, reported results from a latent class analysis to identify similarities and group the first 570 MISC cases reported from March through July into distinct classes. Patients in class 1 had what you might call a typical MISC picture, in which 98% tested positive for SARS-CoV-2 by serology. All patients had cardiovascular and nearly all had gastrointestinal manifestations, often with a number of additional organ systems involved, and markedly elevated laboratory values of inflammation and markers of cardiac damage. These patients had significantly higher frequencies of shock and myocarditis relative to the other two classes, with a very high percentage of ICU admissions. Patients in class 2 had more of an acute COVID-19 MIS-C combination, 100% tested positive by PCR, and patients were significantly more likely to have respiratory involvement with cough, shortness of breath, pneumonia, and acute respiratory distress syndrome. Patients in class 3 were generally younger, with a median age of 6, compared with 9 and 10-year-olds in the previous two classes. They had milder illness and relatively higher frequency of rash and mucocutaneous lesions, most similar to Kawasaki disease. Next slide. The CDC MIS-C website shows the health department reported cases. The most recent January update shows 1,659 cases reported and 26 deaths. That's reported from 47 states, New York City, and Washington, D.C. Average age is 8 years. 57% are male, with 33% Hispanic Latino and 30% Black non-Hispanic. Next slide. This is the epidemiologic curve of daily MIS-C cases. The first peak, as you can see, was from March to June, primarily from cases in the Northeast. And there was a second peak from about June to September, which was largely from the South and to a lesser extent, the Western United States. These peaks followed the first two national COVID-19 peaks by about 2 to 5 weeks. And although not shown here, these patterns were consistent by US Census region. The most recent third peak of the COVID-19 pandemic, which really rose in December and into January in the US, may result in another MIS-C peak, although such an increase may not be apparent for several months because of the delay in the occurrence of MIS-C and additional delays associated with identification and reporting of cases. But I will say that we are definitely starting to see a surge from many states. Next slide. On this last MIS-C slide, I want to share data in which we estimated incidence of MIS-C cases from that first peak time period from April to June 2020 in 7 participating jurisdictions. Our population-based incidence estimates, using a denominator of population of persons less than 21 years, were 1 to 8.5 MIS-C cases per million person months across the jurisdictions. In addition to population-based incidence estimates, we estimated the incidence of MIS-C across groups using a denominator representing total SARS-CoV-2 infections in children, for which we would expect the incidence to be much higher than in the general population. We wanted to assess whether certain racial and ethnic groups may be disproportionately represented among MIS-C cases, even controlling for total SARS-CoV-2 infections. And we found that indeed there's a 6-fold higher incidence of MIS-C among Black African American children relative to white children, and a 4- and 3-fold higher incidence among Hispanic and Asian Pacific Islander children compared with white children. Next slide. Okay, just to summarize, next slide. As of January 24th, more than 24 million cases of COVID-19 and more than 410,000 COVID-19 associated deaths were reported in the United States. Children less than 18 years have lower rates of COVID-19 reported incidence, hospitalization, and mortality than adults. Children are susceptible to SARS-CoV-2, though younger children tended to have fewer respiratory symptoms than adults. And I would add that symptomatic children can transmit SARS-CoV-2. MIS-C is a complication of COVID-19 and has varied clinical presentations. MIS-C is highest and disproportionately so among Black African American children and Hispanic Latino children. Further studies are needed to fully understand the role of children and teens in SARS-CoV-2 transmission and risk factors for severe illness and complications of COVID-19. And that's my last slide. Next slide. Thank you.
Thank you very much for that presentation, Dr. Campbell. We'll open it up for questions at this time. Dr. Paling, please.
Thank you. Thank you, Dr. Campbell, for a great presentation. I may have missed it. I wanted to ask about the MIC presentations and what percentage of the cases are type 1, 2, and 3. Thank you.
That's a good question. And I did have the N, but if you could show, well, I think that might be at the risk of showing you too much. Could you please show backup slide number 40, slide 40? I don't actually have the percentage, but this is more detailed than you might want to know, and you can peruse. But you can see that there were 570 cases included. Class 1 included 203, Class 2 was 169, and Class 3 was 198. This is all the detail on the different manifestations. I thought that since you asked, you might like to see that as well, but it's sort of highlighting the predominant features in each class.
Thank you. Let me ask a question here, Dr. Campbell. So do we have any information on the impact of the variants that are being seen around the world and the incidence of MIS-C? Obviously, if there's more transmissible, we may see more cases, but is there anything to indicate that those variants in any way have leading to more cases or more severe cases of MIS-C?
Yeah, I think all I can say right now is we don't know. We are very interested in that question. We don't have any evidence to support that right now, but we're certainly concerned and are encouraging our partners to submit samples for NS3 surveillance for SARS-CoV-2, as well as there's enhanced surveillance now in which states can submit additional sequences, up to 20 additional samples for sequencing per week. And so we have talked with a couple of states about potentially thinking about submitting additional samples for sequences if they think they're seeing something different. It sounds a little vague, but we've had one state, for example, that was concerned that perhaps they were seeing more severe MIS-C, and it's just not possible to figure that out right now. Because it's also, we're definitely experiencing the expected surge following the rise in COVID cases through the winter. And so we just don't have any evidence to say right now.
Thank you for that answer. Dr. Lee.
Thank you so much for the excellent presentation, and really appreciate the deeper dive into understanding the epidemiology in children a little bit better. My question relates to understanding the disproportionate burden of MIS-C in Black and Hispanic children, accounting for 2/3 of cases, and whether or not there is any further exploration about whether there is biologic plausibility for that versus what I am worried about is that there are disparities in testing rates, particularly perhaps in communities of color. And so if those disparities in testing rates are impacting the denominator in terms of estimating the proportion of MIS-C cases by race ethnicity, and if that has any impact on ascertainment in the initial slides you showed regarding the overall burden of infection.
Yeah, it's such an excellent question. And I am not the burden expert. I don't think that, well, let me state that differently. I do think that the information on race ethnicity is somewhat limited. For example, in the Incidence study that I showed you, there were so many missing data for race ethnicity on many of the children, certainly from the reported cases and even a little bit from the MIS-C surveillance, but less so, but definitely from the regular case surveillance. And so we actually really are kind of putting out an encouraging call for more complete race ethnicity data because it's often not complete. With respect to the under ascertainment bias, I think that the multipliers that take into account all the different factors related to underdetection. I don't think they've done those yet for the different race ethnicities. I do think that is on the table. It's possible that my colleague Melissa Rolfes would have some insight into that. It's on her team, but I don't think we have the people that are doing the burden estimates on the call. I think your point is very good, and I think that we suspect there are multiple factors to this and not all biologic by any means. Ours isn't the only analysis that has sort of found this, but again, if it's a testing bias, then other analyses would show it also. But it really is something that we're trying to get at in finer level of detail. I'm sorry, I think that's the best I can do right now, but I am happy to try to follow up more about what's being done to help get it under ascertainment of various races and ethnicities.
Thank you.
Thank you. Dr. Kimberlin, please.
David Kimberlin, AAP Red Book. Thank you very much for the presentation. I greatly appreciate the expansion of focus at this appropriate time to be considering children and adolescents as we move forward through this pandemic. A question for you about your listing of risk factors. On the CDC website, at least to my perusal, generally diabetes is listed as diabetes type 2. Your slides, Dr. Campbell, just focused on diabetes. Can we consider type 1 diabetics to be at the same risk as type 2 diabetics?
I generally think of type 1 more when we're thinking about the children, honestly, and I don't think that COVID-net, well, I shouldn't say that they don't. I'm not sure if COVID-net collects the differentiation between type 1 and type 2. I feel pretty certain that the COVID-net data showing the presence of diabetes in the hospitalized children would include all type 1 and type 2. But, even coming from my past experience with flu, even then we were never that specific on the risk factor. I did get confirmation from a colleague just now that COVID-net does not differentiate between type 1 and type 2. So all we know is diabetes, but I think that given these are children, type 1 is likely predominantly represented. I think we've never had that level of detail to specifically list type 1 in our high risk list.
And I guess if I could follow with that, I mean, I think as we now are, expanding into, hopefully over the next several months, being able to consider recommending COVID vaccine to adolescents and down into children, and perhaps using a phased approach that could include risk factors, at least initially. I also think of type 1 with children, and I just wonder if the type 2 labeling in the listing of risk factors for COVID disease or severe COVID disease is simply just a bias that's what most adults have. In other words, should the listing on the CDC website, not an answer that I need today, but for CDC's consideration, should that listing just simply say diabetes, not diabetes type 2?
Yeah, Dr. Kimberlin, this is Dr. Oliver. The list is not managed by anybody on the vaccine task force, but we're happy to take that feedback back to the people that manage the list. Thanks.
I greatly appreciate it. There may be a reason for it to be listed as is, but I suspect it just kind of was typed in that way.
And I would say that there's a separate sort of COVID-19 in children webpage where it's listed as I listed it. In fact, I took that list from that webpage. So you're right that it's the more general sort of page that is a little bit more geared towards adults that may say the type 2. But that may be misleading. Your point is well taken.
Thank you. Any more discussion on this? Very good. Dr. Long, please.
Yes, 2 questions. The first is a clinical one. We see children who have MISC, but they really aren't sick enough to ever necessarily be treated for it and get better. And we know that this virus certainly causes a signature innate immune response. So my first question is, if you looked at class 2 and you applied those criteria to adults with COVID lung disease, would a considerable percent have moves of MIS-C? MIS, not C?
Right. Yeah. No, actually, you're right on. We're actually starting to do that. Several of my colleagues are looking through adult charts as we speak. Actually, going through with a general kind of case definition, searching for MIS in adults, and not necessarily excluding those with the primarily respiratory involvement, but also looking for the multisystem involvement and the other sort of more classic features. And it's harder in adults because there is so much more of that severe COVID spectrum. They are finding, and there have been cases of MIS-A, as we sort of term it, reported in adult patients. But we're still sort of in the fact-finding stage about, well, not fact-finding, but in the information gathering stage about adults, because it doesn't seem to be, there's certainly some that seem quite classic, and then there's also the spectrum that's harder to tease out. But MIS-A is something that's not as far along, but we are looking at.
And thank you so much. And the second question is about the epidemiology. As I looked at the MMWR in January of this latest surge, 14 to 17-year-olds are as commonly effective as greater than 65-year-olds. And you've taught us, we've switched to that younger age group. So I'm wondering, in the data that you showed us that didn't really, that with the bar graphs, horizontal bar graphs, 14 to 17s were very impressive. And I wonder if those data include the latest surge in the younger population.
And I'm sorry, Dr. Long, which statistics were you referring to? Sort of overall case incidence, or?
I'm thinking about case incidence, not MIS-C, case incidence in the different age groups in children and incidence in different age groups in children. If we just look at the MMWR of the trends from January 13, and those are weekly incidence case per 100,000 population, I think looking at the dots and dashes that the 14 to 17-year-olds have a higher incidence than the greater than 65-year-olds. 18 to 24 and the 25 to 65 are the highest. And so I wonder if the data that you showed us in the overall incidence includes the most recent surge.
Oh, I understand. Thank you. And just for everyone, if you want to show back up slide 35, she is looking at that MMWR publication. The data I showed you for the reported case, COVID-19 cases did actually go through January 24th, so it did include that.
Thank you. How do you square that? What am I missing?
Well, if we show slide 7 again, the 5 to 17, I don't know. I will say that when we look back, I don't want to hop between slides, but the younger section of that age group and the 0 to 4 certainly were really under tested early on in the pandemic, and so I don't know if this bar for 5 to 17 here is just so low because it had a long way to catch up. I guess I'm speculating a bit, but you're right that they have certainly increased and now essentially kind of lead in percent positive, as you pointed out.
Which will be something important for us to remember as we think about vaccine. Thank you.
Thank you, Dr. Maldonado. Please go forward.
Yeah, thank you. And thank you for this wonderful presentation. It's really important, as you've heard from our other colleagues, to start to really dig into the different social and biological determinants of COVID disease for prevention and therapeutic interventions in this population. One of the questions that I have really is just to ask you if Dr. Elverdeen could bring up also the MISC RFA that was released last year. We have yet to hear any outcomes about how those, I know it's early, but what is going on with those studies, because there was an RFA issued around more biological bases for MISC, and in particular, whether there's racial or ethnic differences in expressions of different biological markers of risk or evolution of this disease. So hopefully Emily will be able to at least comment on this. I didn't see it in her presentation, but maybe we could at least hear about that later on. Or if any of you know about that RFA in particular. Thanks.
Yeah, I don't want to speculate. We recently had MISC and A in a BAA topic list that went out, and that those white papers are under review. But I think you're referring to something farther back, and I'm not sure I know the answer. We do have several, in addition to national surveillance, one large system that I didn't mention that is CDC funded is the network called Overcoming COVID, which initially was Polisi and then Pick Flu. It's basically a pediatric ICU network that CDC had already been working with to look at severe influenza and vaccine effectiveness against severe flu outcomes. That pivoted to include COVID and MISC surveillance and a number of scientific questions around COVID and MISC in children last year. And we are still working closely with that network. And then NIH has a number of MISC-focused studies that they had put out funding requests for and have since awarded with PRISM Music and the RADx Prevail projects. So I know that there's so much going on in this sphere, and as you said, we may hear even more from the next speaker.
You seem not to have any more hands, but let me close with this one question. So there's a lot of focus on MIS-C, but in adults, less than 5% have actually freestanding myocarditis, and we've seen that in athletes. Do we have any data on myocarditis, not MIS-C associated myocarditis, but myocardial inflammatory disease in children as a freestanding condition? Do we have any evidence of that as we do in adults?
It's a great question, and actually those data are coming from the Overcoming COVID-19 study that I just mentioned. There's a paper under review right now comparing MISC to severe COVID-19 children that were hospitalized, and they do have quite a bit of information on the cardiac outcomes in that manuscript. I don't have it in front of me right now.
Right, and one more comment on that. So, with enterovirus, there is a syndrome of chronic dilatative cardiomyopathy that appears years after a primary infection, which can many times be asymptomatic. And, that's always rolling around in the back of my head, that could we be seeing this in 5 or 10 years in these young athletes that are developing myocardial disease isolated without MIS-C? So just something I'm throwing out there.
Yeah, I think it's an excellent point. And there's actually an entire sort of long COVID, I don't know what name they've decided on, but an entire community of practice at CDC devoted to long COVID outcomes. And we certainly we don't want to lose sight of the acute COVID and its complications as well. So we are thinking through those things, and I'm glad you brought it up.
Thank you very much for that excellent presentation and answering those questions. So let me turn to the next topic, which is pediatric COVID-19 clinical trials by Dr. Elverdeen.
Yeah, thank you. So I'm talking specifically on vaccine trials and planning for these trials in children. I have no data on MISC, so sorry to disappoint, but that was not what I was asked to speak of, and I have no additional information. Next slide, please. So the US government effort in vaccine trials for special populations is summarized on this slide. This effort used to be called Operation Warp Speed, but we're transitioning to a different name. The goal of our effort was to bring about SARS coronavirus vaccines for the whole of the US population. And the US government is committed to providing the resources for these trials to occur in pregnant women and in the pediatric population. Under the framework of the US government effort, the company can elect to be the sponsor, and most do. The protocols are approved by USG partners, and those include NIAID, BARDA, engagement, all on the protocol team. The protocol chairs include NIAID-funded investigators, and the partnership includes joint oversight of as the studies are operationalized. And then also a joint oversight team is stood up to resolve any conflicts that might occur in the course of the protocol. Next slide, please. So what is the rationale for doing studies in pediatrics? Well, we recognize, and you just heard from the previous speaker, that the pediatric burden of disease is not as high as it is in older adults, but it still is significant. And as described, there's a disproportionate burden among children in minority communities. And there's both direct and indirect effects to children and all of society. This burden will continue if we don't vaccinate and if we just wait for herd immunity to occur over time. There is early data, really from the Moderna VRBPAC briefing package, that suggests that the vaccines that we have might actually prevent asymptomatic carriage. And if we can do that safely, that would reverse the pandemic more rapidly and be good for all of us. But as far as clinical trials go, safety data does need to be collected, and these are best conducted in clinical trial settings. Next slide, please. So a number of pediatricians months and months ago thought that this was a very important issue to begin to plan for as soon as possible. So this just shows they published a thought piece in CID, and they made the case based upon data really not even a full year of surveillance data in the United States, that the impact on the younger age groups, on children, the burden of hospitalizations and deaths in some cases, compared to other diseases for which childhood immunization was standard in the pediatric schedule. So based upon this and based upon the thought pieces of others, we recognized that it was really important to begin planning for pediatric trials even before adult efficacy trials could be completed. Next slide, please. So NIAID asked a number of pediatric investigators and their colleagues in obstetrics and gynecology who'd previously done vaccine studies to work off of pandemic preparedness protocols for influenza that we designed but not implemented in prior times of pandemic threat for influenza. And they were asked to come up with a shell protocol that would define approaches to age de-escalation and have healthy children for testing these vaccines, and also maternal protocols for immunization in pregnant women, should those be required as vaccines were proven to be efficacious and rolled out. Next slide, please. So this slide just depicts where we stand right now with regard to efficacy trials, which were initially only recruiting in.
Yeah, Dr. Erbelding, we are unable to hear you right now.
Granted by the FDA and in December, allowed for authorized use in individuals age 16 and up. This was because Pfizer amended their protocol, their efficacy trial earlier, to expand from age 18 and up down to age 12 and up. And by the time that they applied for EUA, they had sufficient data in the age 16 and up category to have its use authorized in that age group. They announced last week that they had fully enrolled down to age 12. And I think public discourse in public statements, they have anticipated that they may well be licensed for use sometime down to age 12 sometime in the first half of 2021. It's also been publicly reported that they're planning studies in children under the age of 12 sometime in 2021. For Moderna, which was authorized for use in age 18 and up, also in December, Moderna has launched a standalone adolescent protocol that will recruit the age 12 to 18 cohort called TeenCOVE. And they have announced that they're also planning for younger age groups for starting studies in this group sometime in early 2021. The Janssen product is an Ad26 non-replicating viral platform. It's being tested with 2 dosing schedules in efficacy studies. The one supported by the US government is a single injection. The one that is being supported from other sources and is enrolling global right now is 2 sequential doses spread 56 days apart. So both of those studies are in phase 3 efficacy trials in the United States and beyond. The Janssen, it has been announced publicly that there's an expectation for the company to announce the main results of their US supported trial very, very soon. And they've also announced publicly that they plan to start trials that would gather data for use in adolescents. So that would be age 12 to 17 and younger age groups, that they would plan to initiate those 4 to 6 weeks after the results from their adult trials. It's worth noting that the Janssen Ad26 platform has already been used widely in teens, in infants, and in children. It's a license for use by the EMA for Ebola. And so there is a lot of clinical experience and safety data related to that platform in younger age groups. And you heard earlier today about the AstraZeneca vaccine. This is a chimp ad, which is again a replication incompetent adenovirus vector given 2 doses separated by 28 days. The efficacy trial is fully enrolled in the United States, and the company does have plans to test in adolescent trials and in younger children, but the details of that have not been announced. I'll just mention also that Novavax is the 5th vaccine that is in efficacy trials in the United States. It's currently about halfway enrolled, and I do not have details to provide on their plans, on the company's plans for doing clinical trials in younger age populations. Sanofi will be the next, after Novavax, probably the next US government-supported vaccine to enter clinical trials sometime in early 2021. Next slide, please. So just to recapitulate the 3 different approaches to getting a label indication for SARS-CoV-2 vaccines in younger age cohorts, in the teenage cohort, age 12 to 17 years. There was the Pfizer-BioNTech approach, which was to expand down to younger ages, to expand the eligibility in the adult efficacy trials while they were ongoing. And it seems as though that approach was relatively efficient. They were proven to be safe enough and down to age 16, and now they're accruing more safety data down to age 12. There's the approach that was chosen by Moderna, the TeenCOVE protocol, the standalone trial for safety using the adult dose, which has been proven to be efficacious in the adult efficacy trial. And then there are other approaches that I've seen protocol designs for to expand eligibility into lower age groups from phase 2 trials that originally enrolled adult participants. And these the focus of these, the outcome measures would be immunogenicity and safety. They might explore different dosing schedules. And in order for these perhaps to get regulatory approval, there may need to be a correlate of protection for efficacy from completed adult trials. But those types of designs are also being considered for some of the vaccine products that are currently in efficacy trials. Next slide, please. So this just depicts a schema provided to me by Moderna for their TeenCOVE study, which focuses on the adolescent group. And all of the data, all of the information on this slide is publicly available. The TeenCOVE study opened in, I believe, about December 8th or so. So it's currently recruiting. The target enrollment is 3,000 teenagers with 2-to-1 randomization of active product to placebo given in the dose, the 100 microgram dose spread, 2 doses spread 28 days apart that has been demonstrated to have efficacy and is authorized for use in adults in the United States. So that just gives you one approach or to a standalone teen protocol. Next slide, please. And then on this slide, I tried to illustrate an example, a schema that is an example of a dose ranging study that would occur in younger children. The age de-escalation approach with children divided into 3 age groups. The traditional divisions are age 6 to 12, age 2 to 6, and then infant age to 2 years. And so this is more complicated because there's 3 different cohorts. In some cases, the vaccine developers are testing 2 different doses, with the idea being that many of these vaccines are relatively reactogenic in the adult population, and they may be more so in younger age groups. And the immunogenicity and level of protection with lower doses might be very, very good in children. So the schemas look something like this, with starting in older school-age children, testing full dose or half dose, progressing downward in de-escalating age, testing the dose that might have worked best in older children, and then going down and so on, with the idea that once a dose is identified that is safe and appears to be immunogenic, then moving forward into a larger recruitment, either half dose or full dose, whatever worked best, and proceeding with what would probably be a safety and immunogenicity study over time. Typically, these are designed to be at least 13 months long. So you can infer from this when results might become available in younger age children if the trials start in early 2021. So this is just an example schema. The age groups are often consistent across product developers that I've seen concepts for. In some cases, for example, I mentioned the Janssen vaccine, where there are 2 dosing schedules, 2 different dosing schedules that are currently being tested in efficacy trials in adults, the 1 dose and then the prime boost separated by 56 days. The 2 different dosing schedules might also be incorporated into the dose ranging studies in the de-escalating children cohorts. Next slide, please. So that concludes my presentation. Thank you.
Thank you very much for that very interesting and informative study. Are there any questions from the voting members or from the liaisons? And let me start with this question. So for the adult trials, there was an emphasis on making sure that we had a representative population of ethnic and racial minorities. Given the significant burden of MIS-C alone in pediatric disease, is there an effort to make sure that we have a robust, a very robust inclusion of Latino and African-American children, Asian children in these studies?
Yeah, I agree that that's really important. And I think that the trials funded by the U.S. government would certainly try to, help optimize recruitment strategies so that the diverse populations would be well represented.
And let me ask one other question, since you're alluding to foreign studies conducted in foreign countries. So, and maybe this question should have been directed to Dr. Campbell, but the question is the prevalence of disease in African American, or no longer African American, but children of African descent or Latino children, similar in countries outside of the United States as it is to us?
I do not know. I simply do not know. You mean the prevalence or the incidence of MSC or of
the incidence of MSC? The incidence of MSC. Excuse me for not being clear.
Yeah, I do not know the answer to that.
Okay, thank you, Dr. Paling.
Yes, thank you, Dr. Denning, for this great presentation. And I really appreciated the concept of the shell protocols. In the prior presentation, we saw that children with high-risk medical conditions had an increased incidence of severe disease for COVID-19, similar to what we see in adults. And so I wanted to ask about the shell protocols, which you shared, which are really important. For children and pregnant women, it looked like the focus was on healthy children. Is there attempt to be diverse on the medical conditions as well?
Yeah, I think that's a great question. In the adult efficacy trials, there were, recruitment targeted people at high risk for poor outcomes of COVID disease, COVID illness and complications of COVID, because they were all supposed to be powered to prevent disease, not just to prevent asymptomatic infection. I think, children with a much lower rate of overall of COVID illness, I think the focus would be on the safety profile of the vaccine, as well as in some cases, if the indication for lower dose were part of the objective of the clinical development plan. If that was, immunogenicity would be the other outcome in some of these protocols. But I think it would be important to, have the children who are likely to get vaccinated down the road when vaccines roll out to be included in the clinical trials. So in answer to your question, yes, I think that the effort should be made to have healthy ambulatory children who might represent the U.S. population enrolling in these trials.
Sorry, I couldn't get off mute. Dr. Hayes.
Yes, thank you for this wonderful presentation. I have two questions. One, and you probably are not prepared to necessarily answer either one, but could you please elucidate on what's happening with Operation Warp Speed? You mentioned that is it changing its name? Is it changing its structure within NIH? Can you just answer that?
Well, NIH is a partner in what was formerly known as Operation Warp Speed, along with Department of Defense and along with BARDA and CDC. So all of the partnership still is, still is intact, and we still meet on a regular basis, many times weekly, to continue to move the vaccine development effort and the development effort in therapeutics forward as fast as we possibly can do safely. So all of that is the same. I think the branding is what may be changing.
Thank you. And my next question is, at some point, could we, and this may not be your area of expertise, but at some point, could we hear a presentation on what the protocol is going to be for enrolling pregnant women?
Yes, I think if Sarah or Amanda invite me back or invite a representative of the protocol team back, I'd probably be happy to talk about that as the planning evolves.
Yes, we will definitely continue to keep ACIP and everyone listening informed on on trials in pregnant women.
Very good. Dr. Stinchfield, please.
Yes, thank you. Patsy Stinchfield from NAPNAP. Wonderful presentation. So exciting to see the forward path for for children in vaccines. Question about the age de-escalation studies and the placebo arm. Can you clarify any information you might have about what placebos would be considered?
Well, as I mentioned, none of these trials have launched yet. And usually the active vaccine to placebo ratio is, 2-to-1 or 3-to-1, something. It's not in the designs that people are considering, it's usually not 1-to-1. What placebos are being considered? The control in the United States, the control condition, it hasn't been proposed that I know of to be some other vaccine like tetanus or meningococcal or whatever other things might be introduced. So I haven't heard that being proposed as a control condition, but it would be a consideration if that was the best approach ethically. It might be a true placebo, saline or not an active vaccine. Is that what did I answer your question? Was that what you were getting at? Okay.
Yes, thank you.
Thank you. Dr. Kimberlin.
David Kimberlin, AAP Red Book. Thank you very much. As I said with the last speaker, it's wonderful to hear this expansion of discussion to include the pediatric population. You had a slide that talked about approaches to label indications for vaccination in the teenage cohort, 12 through 17 years. And the third bullet was expansion or to expand age eligibility in phase 2 trials for immunogenicity and safety. And you mentioned about a correlate of immune protection. Can you speak broadly as to where that stands in the multitude of studies and data coming in? Are we closer to getting that correlate of immunoprotection in adults?
That was from the very get-go when the government was planning these studies together with the companies. We knew that the correlates of protection would be a high priority. Of course, identifying a correlate of protection requires usually breakthrough infections in the vaccine arm. And the first 2 vaccines that were authorized for use, the mRNA vaccines, were so highly efficacious that there were very few vaccine breakthroughs. But more data accrued, of course, because there's a lot of virus being transmitted out there, and there were a lot of COVID cases even after in the trial after the authorization was granted. So groups of laboratorians, biostatisticians, the companies are actively engaged in identifying correlates of protection for the authorized vaccines. There's also NHP studies underway with all of these vaccines that are in efficacy trials to see whether correlates can be identified with breakthrough infections in those groups. And so that might actually provide more robust data if a correlate is identified or implicated in the efficacy trials in humans. If the correlate correlates with what was seen in non-human primates, then there would be even, I think, more validity in using that for a marker of protection as we move forward into studies that rely or licensure that might rely upon a correlate of protection. Was that clear?
It is. Any speculation, and of course it'd be just speculation on when we might get there?
Yeah, I think people are hopeful that for within the next month or two, a correlate of protection would be identified for these early authorized vaccines. Then the question remains, of course, whether it's going to be different for a different platform. That might be true. So there might be correlates that are particular to one vaccine, but might not be as useful in others. So hopefully, short answer, hopefully in a couple months.
Excellent. Thank you very much.
Thank you, Dr. Maldonado.
Yes, thank you, Emily, for that really nice overview. And I realize that you were focused on the vaccine issue. I did just find out that the MISC RFA was awarded already just recently, but look forward to hearing more updates about those as they are, again, biologicals correlates and could potentially be useful for understanding some correlates of protection as well. The question I had is around, of course, we're excited at the American Academy of Pediatrics that pediatric trials will be moving forward, and we hope those will be more moving forward safely and quick and efficiently and quickly. But the other question I have is around pregnant women, and my understanding from some of our community partners, OBGYN in particular, are concerns, and actually in our attempts to try to partner with them to participate in some of these pregnant women trials, that some of these individuals and groups are concerned about the ethical implications of enrolling in a placebo-controlled trial when vaccine for pregnant women has already been given, especially in the healthcare 1A sector. So I think it would be helpful to partner with ACOG and other groups to make sure that these trials are really carefully spelled out, because we're already seeing refusal, at least in our community, for participation in proposed trials in this important group. Thanks.
Thank you. We're going to take one last question because we need to break for lunch and promptly resume at 1 o'clock, or well, at the hour. So Dr. Daly, last question, please.
Okay, yeah, thanks so much, and thanks for that presentation. Could you just discuss a little bit more the steps involved in getting to authorization for 12 to 15-year-olds for Pfizer and 12 to 17-year-olds for Moderna, and at least sort of what you'd anticipate the timing of that to be?
So you're asking me to put on an FDA hat?
Well, just from your vantage point, what are the next couple steps that are going to need to happen there? Not from an FDA vantage point.
Yeah, so the Pfizer trial, as I mentioned, Pfizer announced that it was fully enrolled down to age 12. And so one could infer that, they'd had prior discussions with the FDA on what was an adequate number, and that they achieved enough enrollment to reach their objective, which I know is going to get authorization down to that age group. So I think that, whatever the required follow-up for safety would be, and whatever Pfizer's timeline for moving forward to licensure would be, which, as I understand it, might be, definitely first half of 2021. I'm going off of what I've read in the newspaper here. That would be when down to age 12 might be an option for might have the option of getting vaccinated. So that's Pfizer, fully enrolled down to age 12. But the Moderna approach was to do a teen-specific trial. And that is also open and enrolling and not fully enrolled yet, though. So, timeline there would depend upon how quickly it can enroll and what the FDA would view as, a good amount of safety data for that age group.
Thank you.
Dr. Doran, not to put you on Dr. Fink, sorry, on the spot. Do you have any comment?
Sure. So, first of all, FDA is continuing to engage with individual vaccine manufacturers regarding the contours of their pediatric development programs, not just studies that are currently underway, but studies that are still in the planning stage. We are considering issues that include the number of subjects in certain pediatric age groups that would support an acceptable safety database for a regulatory decision that might first involve emergency use authorization, and then with some longer term follow-up, be supportive of biologics licensure. We are also continuing to discuss the immune marker parameters that would support bridging of effectiveness from the adult population into pediatric age groups. Certainly, if there were to be an immune marker scientifically established to predict protection against COVID-19, then that would make the job easier. But the absence of such an established marker is not necessarily prohibitive. We do have regulatory experience with immunobridging approaches in situations where there is no immune marker that is established to predict protection, although there are a variety of considerations that make it more or less easy to navigate such an approach, including whether you're talking about the same dosing regimen as was evaluated in the adult efficacy population, and also whether there is reason to believe that the parameters of the immune response in the pediatric age group would be similar to that in adults or different. And certainly in the adolescent groups, we have a very high degree of confidence that the immune response parameters would be similar to those in younger adults.
Thank you for those comments. Thank you, Dr. Verbolding, for that presentation and for answering the questions. For everybody on the call, we are going to start back up at promptly at the hour. We're going to have the opportunity for Dr. Walensky, the new head of the director of the CDC, to please address us. So promptly at the hour, we will start. I'm sorry about the shortened lunch, but you can always nosh at your computers.
Yes, Dr. Romero, that would be in 10 minutes. So 1 p.m. Eastern Standard Time and different hours for the rest of you. So thank you.